Good afternoon, everyone. On behalf of everybody at State of Reform, thank you so much for your active participation today. As always, these events are wonderful convenings for like-minded professionals who care deeply about our healthcare system, particularly our publicly financed healthcare, Medi-Cal and Medicare. It's a great way for us to convene, to share best practices, and to hear from leaders, thoughtful leaders, about what they're doing, what keeps them awake, what they want for the future, and what they're doing to achieve that in their zones and spheres of influence. It is my great honor to say hello to all of you. My name is Margaret Tater. I'm a vice president at Health Management Associates. Have been at Health Management Associates for about 10 years. Before that, I was in plan leadership at a couple of public plans here in California. Started out life a million years ago at CMS in Baltimore. So this is very much in my DNA. I am delighted, absolutely delighted, to invite you to share the wisdom of the panel that I would like to introduce right now. These three colleagues and esteemed leaders lead large plans here in California. They lead large plans with multiple lines of business. They are focused on excellence. They are focused on complying with and actually maximizing the benefits of the policy changes emanating from CMS and DHCS in connection with the CalAIM waiver and all the myriad ways in which we are collectively attempting to address the social determinants of health and bias that is in our system. However, our colleagues on the DS today are also colleagues who have successfully led large plans for a long time. They understand the challenges of these new programs, services, and benefits. They have navigated this incredibly complicated year with great success. So we have a few themed questions, but before we get started, I'd like to turn to my left and invite Martha to introduce herself, and we'll go down and we'll allow everybody to introduce themselves, and then start our questions. Thank you.
All right, well, thank you. And excuse me, I was reflecting in the back of the room of, being a closing session. Sometimes people stick around, sometimes people don't. It feels like we had a knack and we kind of cleared half the room, so that's good, right? Less questions. But I was sharing with Dan back there that I've been on the other side, right? When you're, it's the end of the day, and you've worked it all out all day, you're exhausted, and you head out. So hopefully for those of you that stick around, this is really helpful. And we're approaching this as a conversation, because that's really what this is all about, having conversations and dialogue with one another to make things better. My name is Martha Santana-Chin. I am Plan President for Health Med of California. We serve multiple counties in the state, all lines of business, roughly 3.5 million members, 2/3 of which are served by government programs, primarily Medi-Cal, and also the Medicare program. And I'm just delighted to be here with you today.
And good afternoon. It's great to be with you. My name's Jarrod McNaughton. I'm the CEO of Inland Empire Health Plan, just to the east of us here, serving San Bernardino and Riverside counties, about 1.5 million members in the covered California world, Medi-Cal and DSNP. And the three of us actually were together today virtually for our DHCS CEO call. So some of the questions that we're going to talk about, Margaret, actually were brought up on today's call. And so it's very timely. And I loved this last panel. I think that to John Backus's point, all of us really are absolutely in support. I know we're going to get into some of that later, but we're very supportive of trying to do exactly what that panel was sharing previously. And so I'm excited to be with you folks today, and just great to be with my colleagues too.
Good to be here. Michael Hunn, CEO at Optima Health in Orange County. So nice to see everybody here. We insure about 1 million people in Orange County. There are 3.1 million residents in Orange County, so about a third of the county of Orange is low income or live below the federal poverty level. And we are fully ensconced in all things CalAIM these days. We're traversing all the new state rules. We have all the same challenges as the last panel just spoke about. And we look forward to having a dialogue today about substantive things. I think as we look at healthcare reform and we look at policy and we look at gaps, we're always going to have them. We're never going to solve it all. But I think in a collaborative model, there's a lot that we could accomplish to be better together. So I'm hopeful that we'll come up with some generated ideas to do that.
Thank you all so much. So the first topic that we wanted to take up is the topic of health equity, a central tenet of CalAIM, this waiver, and very likely will figure prominently in California's successor waiver to CalAIM. Certainly the plans have had numerous requirements in the new contract relating to health equity in terms of process, administrative functions, et cetera. But for purposes of the leaders on the panel today, we thought it would be interesting to hear from them and to cast out their crystal balls and imagine what we see in health equity programs and outcomes for the next 2 to 5 years. And then, frankly, what we could hope to achieve, what would be indications of progress in this area by perhaps 2030. What would we see in 2030 that would indicate that what we have done in 2024 has made some sense and has mattered? So looking forward to your comments.
All right, so I guess I'll get us started, and I'll chime in here. So first of all, I think the prior panel talked about that we have good problems here in the state of California. HealthNet is owned by a national organization, and we see the gamut in terms of what Medicaid programs offer and the design of the programs bring. And we've also seen the impact of policy and decisions that are not so focused on doing the right things for vulnerable communities and marginalized populations. And so, I'll start with saying we have an awesome problem to deal with in trying to advance health equity, and we're personally and our organization is very grateful for all the investment that the state has made in this regard. In the short term, in the next 2 to 5 years, there's already been a great deal of collaboration, organizing, a willingness to have conversations about how to break down silos, how to build systems, how to make sure we're supporting the social drivers of health in ways that we may not have necessarily thought of before. Part of it is by design, right? I think the state did a good job in at least providing a framework that fuels collaboration, organization, and breaking down of silos. So I think that framework is a good framing of the work that's ahead of us and what we've got to actually do to execute. There's a lot of willingness. People are talking about health equity, whether it's a community-based organization or a physician or a hospital. And so I think just the energy behind being able to focus on this together provides a platform that we can build on. The reality is that progress will be incremental, right? We are dealing with decades and generations of underinvestment, of policy decisions that have had intended and unintended consequences that are really providing barriers to the communities that we serve, and we're not going to be able to turn the ship overnight. So in the short run, there'll be bright spots, right? We've already seen some bright spots with communities that we're serving and learning about their needs and how to break through to really help improve preventative care as an example, or access to care as another example. And so that incubation of ideas, that willingness to collaborate, that organizing, the breaking down of silos will continue for the next 2 to 5 years. In the long run, 2030, what I'm thinking is that we'll begin to see the development of the scaffolding that's necessary to have systems change really stick. Again, it's not going to happen overnight. And it's going to take all of us to really do that work, but the collaborative efforts that were the foundation of CalAIM are really the impetus for what's going to catalyze that impact and that improvement. And you know, as you think about the systems, we're talking housing, we're talking, you know, we just heard about behavioral health. There are social programs out there, community-based organizations, nonprofits that have all played a role. And so breaking down those silos will definitely take time, but over time there will be incremental improvements, we believe.
Yeah, thanks, Martha. Totally agree with you. I remember a couple of years ago, Margaret, when we were at a California Association of Public Hospital Safety and Institute board meeting. It was in a hotel like this, and we were sitting there, and I turned and talked to Chris Perrin from the California Healthcare Foundation and said, hey, we really think we could use your help on this equity requirement in the contract that's coming, and how to make sure that some of the work that's happening across the state is at least there's a playbook for it. Because, you know, in the contract, when you go through it, there are some requirements there, but there's a lot of vagueness as well. And I'm really grateful that folks came together, the health plans came together, we had outside folks come together to look at what could those JDs look like, those job descriptions look like for our chief health equity officers as required in the contract. What should we be doing in the organizations to address that? And I am thrilled that all of our organizations really have, I think, done a good job to make sure that it's tailored to the communities while having kind of a thread run through it of some commonalities. And for our organization, the big piece that we really took just a deep dive on was the algorithmic bias issue that we figured out was we were having problems with in the data. And really making sure that our team understood that from the quality side for HEDIS and MCAS measures, those outreaches to CBOs that we partner with, and what are those specific things that we can do to overcome the bias, but also at the same time make sure that our teams are educated about it so that when we go out and talk with providers that we're doing it together and making sure that their teams are just as aware as we are, because all of us were on this massive learning curve. And so I'm really thrilled that we're moving in the direction. I agree with Martha 100%. It's going to take some time. I mean, we're talking, it will take time. But I think it's the right thing to do, and I'm really excited for the horizon ahead on this one.
So I think there's a need for focus. I tell our team quite frequently on the management side, we're not here and I'm not here to admire the problems. So let's be clear about what it is that we're looking to solve. And I think in health equity and all things equity, I've seen a lot of chief health equity officers hired. I've seen new ones being hired. I've seen change in focus. There's been a lot going on in that area over the last couple of years. So in the contract, as Jarrod mentioned, we are required by DHCS to have a chief health equity officer, and that job is prescriptive. And so I had our chief health equity officer take an Excel spreadsheet, put all the requirements in the job description that the state gave us, and then figure out a report card that she can present back to us to say, here's how I'm accomplishing what the state wants. And then I said, is there an audit tool that the state's going to use to validate whether or not we're meeting the criteria? Of course, that hasn't happened yet. So then the question is, what do we do? Is this an internal issue? Is this an external issue? Is this an outward focusing equity issue in the community? Is this DEI? Is this about the CBOs and the provider networks? Help me understand what it is that the swim lane needs to be for us to be successful in all things equity. And then I think ultimately being very clear, let's define it. What is equity? I think a lot of folks started off with, oh, equity was DEI. And that's kind of gotten blended in, but that's not what equity is. Now we're taking an approach where housing is health, food is health, access to health care and behavioral health is health. And we're going to stick very strongly in those three swim lanes. And I think from a health equity standpoint, we're in a county that has a very defined geography, Give me an ambulance and a siren, and I can make it from one end of Orange County to the other in about 35 minutes. We've got the ability to influence the community pretty strongly because we insure a third of the population. So now from an equity standpoint, how can we apply that to CalAIM, the managed care provider network? We have delegated groups. We delegate about 75% of our almost million members. And what are we going to do to make sure that food is health, housing is health, and access to healthcare and behavioral health is health? So I think between now and 2030, it's going to have to get clearer for everybody as to what the expectations are that the state actually has about what they expect us to achieve, quote unquote, in equity. And then finally, if I boil it down to a very simple definition of equity, and I've seen a lot of them, I've seen a lot of attempts at it, but it boils down to, am I being fair to you? Is it fair to you? Is it fair to you? Is it fair? And so if we can apply the resources, the policy, and ultimately the outcomes to, was it fair for everybody? I think that'll at least get us started.
Thank you all so much. I think this conversation underscores, frankly, the magnitude of what the plans have undertaken in this past year to address and operationalize many of the key and valuable tenets in CalAIM, which kind of pivots to another theme of questions, and that is how we've implemented CalAIM in this past year, the past couple of years actually, since the waiver's been in effect. CalAIM was, by all accounts, certainly from my tenure in California, CalAIM has been one of the most ambitious waivers in my 20-odd years here in California by a long shot. New benefits, new obligations, a new focus on the plans as being this integrator of all things health, whether, as Michael said, health is housing or health is food. It is a demonstrable refocus and reimagining of the role of the health plans in the pursuit of equity and addressing the social determinants of health. As we think about the next waiver, and we'll talk a little bit in a couple of minutes about that, but as we think about the next waiver, very interested in observations from our leaders about what we learned from the implementation of CalAIM. What did we learn about the pace of the implementation? What do we think that DHCS might have learned about the pace of the implementation? And what did we learn, for example, about the basic tenets of change management that had to be deployed and had to be deployed fairly quickly in all of your organizations to keep up with the pace of operationalizing this very ambitious waiver? So curious about your observations on what worked, what didn't work, what was right paced, what could have been paced better, and what you all learned about change management.
Okay, Martha. Well, I'll tell you, CalAIM, my Xanax bottle's empty because of CalAIM. It's just been an incredible journey, Margaret. I'll tell you, for our organization, definitely the right thing to do. I mean, I think all of us can agree, absolutely directionally right thing to do. To your point, the most transformative thing to ever happen in the Medi-Cal program in the state's history. But there are a lot of lessons that have been learned. The big one, of course, in fact, some of you know Bobby Winch, who was kind of one of the grandmothers, I think, of the managed care plans in California. Yesterday, we had her on our campus, and we were just talking about this very issue, that really this is at least a decade out before you even know, really, is this working? And as the panel previously shared, and as John Back has shared from LA Care about some of the other pieces that have to fit into all of this, it's so true. In our organization, we actually had to make some pretty big shifts pretty quickly for things like ECM teams, where we had 15 plan-based ECM teams. The state didn't want them to be plan-based, they had to be provider-based. We had to create a whole separate entity to do that. That's very unusual. At least it is for the public plan side to have to do that kind of thing. the rates are not keeping up with utilization. I mean, our community supports, we got about 10 million for this year. We're on a run rate of 50 million, 5 times higher than what the rate is as far as utilization. So the learning on this is going to evolve and continue. And I think as time goes by, I'm hopeful that the state, and with Michelle and Sarah and Tyler, that whole team at DHCS, I think they're really interested in getting feedback. I really do feel they're genuine. And I think it's our responsibility to make sure they're getting that real-time feedback as fast as possible. And as the plan, responsibility to really be the convener and the communicator. Listen a lot to those providers, to those community-based organizations, all of that CHW team, and really try to make change within the plan as fast as you can to address those needs. So for us, it's been an exciting ride, but boy, I'll tell you, it's been pretty wild.
Yeah, I think on our end, we decided early on to jump in with both feet. So we implemented all 14 community supports. We hired an executive director at CalAIM, and we immediately started launching programs. And we had to hire staff that were used to running programs, not just adjudicating claims and pushing paper around a 9-story, 10-story glass building. And so as a result, we've been able to really work closely with the community. But we discovered very quickly that there's a lot of good going on throughout the county, but a lot of it's not coordinated. There are silos of excellence all over the place, but the right hand, the left hand, and the left foot and the right foot don't know what each other are doing. And there's also a lot of cross-purpose of duplicated infrastructure, and so that gets frustrating. So we discovered that we needed to be a convener and pull everybody together and start describing what everybody else is doing. And I think that's been a good lesson learned. In addition, we discovered, like most have already commented, folks didn't understand the ECM component of CalAIM, and so we created an ECM Academy, an education program to teach people how to do it. We've done billing sessions. If somebody wants to learn how to do Medi-Cal billing and drop a bill to us for our direct members, we'll show you how to do that. We'll have ongoing classes and orientation. We put together descriptions of each of the 14 community supports so that folks could understand what they're looking at in terms of availability of those services for our Optima Health members in Orange County. And that extends to care managers, case managers, community clinics, the federally qualified health clinics, the schools, both Title I and non-Title I, and the other community organizations that we work with. There's a great coalition in Orange County of community clinics. They see about 300,000 of our members, see about 1 million visits a year. Just that group alone in navigation during redetermination and the implementation of CalAIM was instrumental in us really being successful at getting the provider access out there, as well as getting these services online. The in-home security, making sure you don't fall, grab bar, pick up the mats sort of thing. The rent assistance for transitional, the money that we put out through SB HIP, the money that we put into the food and dietary medically tailored meals. And so there's a lot, but we had to pivot from being claims adjudicators to actually service providers and then build an audit infrastructure to go with it. And then our board approved an audit tool that was given to a third party. So now we're having an audit of our audit by independent third party auditors, because we know at some point with all the money that's flowing into CalAIM, there are going to be audits. I'd rather be ready for those than not. But at the same time, we're teaching our community-based providers downstream to audit what they're doing and have a report that says, here's what we've actually accomplished. I'm also interested in the statistical data that goes with the outcome. It's nice to be busy, and another thing I tell the team, don't confuse activity for accomplishment. Show me the numbers. So I think we've gotten much better at it, more to go.
And I think I'm going to focus on the pacing part of your question just for a quick second. So, I think the first thing is context matters, right? When CalAIM was first being imagined or discussed, we were in one state as a state. When we started to roll it out, we were in the middle of a pandemic. Our providers were reeling from having to care for the needs of patients that were in front of them then and there. Many of the community-based organizations were also impacted. Health plan staff was impacted. State staff was impacted. We were in the middle of trying to figure out how to stand up e-consult or telephonic consultations for our Medi-Cal population who had before that really didn't have a whole lot of access to that. So we were in the middle of a tremendous amount of change. And all of our providers were impacted heavily as a result of that, as were we as health plans. You then go into 2022 when we first started to roll out the CalAIM program. At that point, pandemic was not over. We were still dealing with that. Our people were tired. We were tired. We started to see a lot of turnover in staffing. The discussion about burnout just elevated several levels from where it had ever been before. And we were now in a position of having to implement a brand new program, which, by the way, was definitely very ambitious. For HealthNet alone, we had to onboard close to 300 providers who had never worked with managed care plans before. These organizations were accustomed to working with grant funding, philanthropy, whatever they could do, but it wasn't like they even understood what an ICD-10 code was, right? And so it was a lot of change for them. It was a lot of change for our hospital partners, for our doctors, for our staff. And so I want to start with just saying context matters, because when you think about systems change, those things take a considerable amount of planning. Kaiser, when they implemented their medical records, their EMR, it took them 6 years to implement the EMR, and that was a contained system. On the private, office-based physicians, adoptions of EHR, it took 13 years to get from 17% adoption to 78% adoption. It took Uber 2 decades before they figured out how to be sustainable. And so I start with that because, we're now in a position of being able to build on what we've got. The CalAIM program, really, it's 2.5 years old. And we didn't have the luxury of the, advanced planning. We had to just go and start. And so pacing is important. I think we have a foundation to build on. Community supports is an example. Many of us went all in on providing community supports because we fundamentally believe that addressing social drivers of health is critically important to getting people to focus on their health and well-being long term. But those services are only services. They're optional at this point. And, another number that I'll share is in our health plan rates for HealthNet, we have $30 million allocated for the expense associated with community supports. We're on track to hit $125 million by the end of the year. But the rate setting process doesn't align with that, because the way the state sets rates, it's 2 years in arrears, 2.5 years in arrears. And so when we talk about the next waiver, context matters, right? We have to build, we have to refine and modernize the way that we're running these programs so that we can keep pace with the change that we're introducing, funding these programs effectively and not regressing, right? Because the other danger here is, the reality is we're in a tough budget situation, right? There's new leadership that's coming in and out of the state all the time. So I think it's incumbent on us and many of you to have a voice at the table with the department on an ongoing basis and take advantage of those stakeholder meetings and submit feedback, because that is what it's going to take to make sure that we don't set ourselves back and not progress and advance on the work that we've already done. And so, that 2.5 years, the last thing I'll just say is setting expectations is critically important. There's endless articles that reporters of wanting to publish or have been published around the lack of success in the CalAIM program. We're trying to deal with generations and decades of issues. 2.5 years with not a lot of lead time to implement this is really not a fair expectation to set that by this time, we should have achieved a certain level of performance. We're getting, all plans, I can, speak for all the health plans, we're all continually getting better and working with our providers, but there's still a lot of work to do, right? Some providers have figured out how to do the billing. Others still have not. We've all invested a considerable amount in technical assistance, but the uptake's not where it needs to be. That said, we are making progress. We can't go back, and I think it's really important to continue to build on what we started. If we don't want to leave people with false promises.
Oh,
If I could just
Go
add
ahead,
another
Mike.
point. So to that end, as we look to measure the outcome and what impact it has, we had a DHCS call this morning, and I made a recommendation to Director Boz around information sharing. When we were in the pandemic, we were working with our social service agency. As you know, they're the ones who do the sign up for Medi-Cal, not us. And then we exchange data between each other, and we get a file that says, okay, here are your new members, or here are the disenrolled members, and we update our system. Heretofore, we couldn't update an address. We'd have to send it over to SSA. They would then validate it with the state. Then they'd say, well, maybe we accept it, maybe we don't. Then they would put it back in the file and then send it to us and say it's okay. We couldn't even update an address, really. So the suggestion this morning was, could we get an MOU around data sharing between us and the counties? Imagine if we could share data on behavioral health, if we could share data on CalFresh, if we could share data a little more intently on services needed by individuals, if we could cross-coordinate it with SSA, the healthcare agency, the behavioral health agency, and the health plan, and the provider networks, and dare we say the community clinics, and those that are actually taking care of our folks to cross-coordinate. This is coming into keen focus for us because we've implemented street medicine. We're in Costa Mesa, we're getting ready to launch in Anaheim, and we've been in Garden Grove for a year. And so what are we going to do with that cross-data information on that individual who's homeless on the street receiving the care? So as we look at these initiatives around CalAIM, community supports, outreach, and we look at the policy, gosh, isn't there something we could do on the sharing that the lawyers keep saying, no, you can't, no, you can't. So I told Director Boz this morning, maybe you can put together a model MOU and send it to everybody and say, we encourage you to do this. If we don't get this down to the individual who we're actually trying to help, then I think we will experience greater gaps in care for that person.
Well, and Michael's comment really underscores the reality of the state's goal of trying to do truly integrated care and putting the plans in the position of being that sort of focal point of integration. You can't do fully integrated care unless you have access to the data of all the other delivery systems that are impacting the members or that are contributing to their care. I think it's just a great gift that we have leaders like Martha, Jarrod, and Michael, because I mean, you can tell how hands-on they have been in connection with all things CalAIM implementation and truly endeavoring to make it as meaningful as possible given the obvious constraints. Interested in hearing their observations in our remaining time about what is achievable, what we think may emanate from the next waiver. Certainly, I think we can anticipate conversations to start emerging in the coming months about what ought to be in the next waiver. Certainly, a lot of people think that the next waiver will continue to focus on health equity, on ever increasingly focused integrated care for vulnerable populations. We have a roadmap from the prior panel about what we could do in connection with reducing silos in behavioral health. But for purposes of our panel here, we'd like to spend the remaining time talking about what's possible in the next waiver. What does that next phase of integrated care for vulnerable populations look like? And what lessons do we want to bring to the conversations with CMS and DHCS in terms of making these goals achievable? Thank you.
They're all looking at me. Okay, great. Yeah, I took my blood pressure medicine this morning. I'm good to go. I do want to remind the other panelists on the last panel that this was recorded, so all their comments will be in living color. So for the next waiver, from a managed healthcare plan standpoint, and I had this conversation recently with our CFO and some of our staff, I think us having direct conversations with CMS are in order. I don't know if John's still in the room, but if you take 2.7, 2.8 million lives at LA Care, I think 1.7, 1.8 million at Jarrod's shop at IHP, HealthNet at 3.2, us at about 1 million. You add all that up, we substantially represent the state of California. 4 people went and sat down and said, okay, we're responsible for 9 of the 14.9 million people in California with Medi-Cal. Here are some things that we've learned as the lessons in our communities. Here's what's happening at the line. And the waiver should align with solving gaps in policy, funding, and healthcare delivery that actually makes sense. Right now, that's all filtered through DHCS, and I get how it's structured. I get the way that it works. I get the way how money flows from the feds to the state. But at some point, I think we need to have direct dialogues about the practicability, if you will, of what we're trying to accomplish with the resources. In the waiver, I think we need to focus on 3 things. 1, there has to be an alignment, particularly in behavioral health. We cannot continue to ignore this problem. 2, I think there needs to be clarity around rate and rate sustainability. The state next year is purported to have a worse budget issue than this year. The actuarials are already spinning up to figure out how they can reduce risk and reprice everything at a lower price point to cut into the revenues, and that'll put it back to the state general fund. I get that the governor has to balance the budget, and I appreciate that machination, but at what cost? And then finally, we can't put people on a train, give them all this support, feed them, house them, get them access to care, and then the tracks run out and everything just falls. That's the model. That's what's been going on for years. I don't think that's fair to human beings. I don't want to see that happen. And in the next waiver, we need to have some long-term sustainability, which hasn't been the model out of DC, hasn't been the model out of the state. But I think there's a time now for us to say, letting people just run to the end of the railroad tracks and fall off is not a good idea. So I think that might be a little bit of a starting point.
Thank you, Michael. Oh, I'm sorry, Martha. Go ahead.
So I'll just add a couple things. You know, one of the things that, I like that idea, sign us up. One of the things that's also the reality is, I'm sure you all see it, there is waste in the system. There's waste, right? We see it every day. We've got a mechanism to finance and to pay for care management services. And many of these county-based entities and community-based organizations, for good reason from their perspective, don't want to give up their traditional funding streams to flip to this other mechanism. And it's fear, it's uncertainty, like I certainly understand it. We've got to get past that. Because this patchwork of financing, whether it's for these kinds of services, or I would argue even for the way that hospitals get paid and county agencies get paid, create cost that may not be necessary. And so as we think about the next waiver, is there an opportunity for us to better align the financing so that we have more transparency in the way things are funded, and ideally more money to work with? Right, because there's more need than there is funding. So, as we're thinking about the silos, I think the financing needs to go along with that.
Jarrod.
I'll just quickly, I know we're out of time, just quickly share what I get most excited about. I'm very grateful the Secretary asked the plans to actually be a part of developing that next waiver. I know our CMO, Dr. Takashi Wada, is part of that LHPC committee to do that. Thrilled for that. What gets me excited, I mean, we've got to stabilize what we've got right now for sure. But looking forward, I really am curious to go down further on that fully integrated plan piece. That really gets me excited. And it's mentioned a little bit in the current one as an optional thing in CalAIM, but there's not a lot of meat on the bones there. And I think it will address a lot of the issues that were actually brought up today to go down that path in partnership with your counties and really have a uniquely different way of looking at the entire continuum of care. So that's probably, for me, Margaret, what I get most excited about. Very scary. You know, it's a big, big kind of whoa, 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 but it's really exciting too.
Oh, indeed, indeed. We are regrettably at time, but we did want to see if any of the folks in our audience had questions or comments for our CEOs. We are deeply grateful to all of you for continuing with us this afternoon. I'm deeply grateful because it's fantastic to hear thoughtful, hands-on, and inspiring leaders who not only manage what's in front of them, but think very, very, very strategically about what's out there and to come. So please join me in thanking them for their thoughtful comments this afternoon. Thank you all. Yes. Yes.
You almost got away, John. We had to sit back down.
Thank you all for sharing your insight. I'll try to speak as loudly as I can. You know, in discussing the indications of health equity progress, you know, a lot of the conversation was focused on system level processes, which makes sense because you all work at the system level. And, you know, it's very informative and very insightful, but I kind of want to bring it back down to a basic level of, you know, on the ground, asking you all, you know, what does health equity progress look like given the various public health needs of the communities you serve, or even the larger regions you serve? What does that look like to you?
Well, I'll sure share my thoughts on this. I mean, just a couple of weeks ago, I went out to one of our homeless camps, and I was visiting folks in one of the camps, and there was a 7-month pregnant woman that had never been seen by a physician and didn't even know she was a member of IHP. And our team didn't have a track on that either. And so until, to your point, it gets that granular, I mean, the minute that we figured that out, the teams got her in the next day to an OBGYN. I mean, they did all the stuff they should have done. But that is, for me, a perfect example that should never have happened. It was a failure of the system, a failure of the equity piece, because just because she's homeless does not mean that she does not absolutely have to have that care and deserves it and needs it for she and her baby. That, for me, is a real practical example that I just witnessed. I don't know if my colleagues want to share.
Yeah, I mean, the thing that I would share is that it does start with data, right? It starts with the system, it starts with data, right? We've got to make sure that we're identifying the disparities in specific communities. It could be a zip code, it could be a city, it could be a part of town. And when we're finding those disparities in the outcomes that we're trying to drive or the access to care, we've got to tackle it at a local level. That could mean a collaboration with a physician or a clinic and or a hospital and or a community-based organization to make investments locally to address that gap, that disparity for that population that we're serving. You know, I'll give you an example. We've had issues with immunizations in the Russian population in Sacramento as one example. When you break it all down, there are cultural issues that have to deal with that, but at the end of the day, it's about the support around it. So going from a macro level, what does the data say, identifying where you're going to focus, and then targeting interventions with partners at a local level to help those families and those people individually is really what it's going to take.
And just briefly, we're going with trusted partner models. So we did a back-to-school event. It's the second year we did it. We had 5,200 folks show up. That's the largest single group that's shown up for a single event. And we did it with 60 community partners at a school in between Tustin and Santa Ana. Santa Ana has about 320,000 residents. We insure 156,000 of them. Irvine is our 5th largest city. There's 301,000 folks in Irvine. We have 51,000 CalOptima Health members, Medi-Cal members in Irvine. And so we're discovering everything has to be local, has to be by neighborhood, and we have to look at the equity issues in that community with local government. We now take that roadshow to city council, and we get up, and you should see the look on the city council's faces when you tell them that they have 50,000 people in their city that are low income or live below the federal poverty level. And this is in between Newport Beach, Laguna Beach, Huntington Beach, Seal Beach, Dana Point, all these ritzy, alleged wealthy places. And here's this community of individuals that we're responsible for that we have to take care of together. So what's fair to them? What's fair in the delivery of city services? What's fair in the delivery of county services? I wish Dr. DeMarco were here. They're flagging us. And then finally, I think if we're going to do it by community, it's also by individual. And we're taking that real seriously. So that, to me, from an equity standpoint, is where we have to continue to go.
I think your question is great. I'm glad we're closing with it because I've been in the Medicaid program federally at the state level and in executive leadership positions at plans for over 30 years. Medicaid as a program has all the requirements, has always maintained requirements for timely access, access to coverage since its inception. We have always had those baked in. But what we are upon now is the imperative of delivering on that promise. And I think that the comments from Michael and Jarrod and Martha really reflect the knowledge that notwithstanding the fact that access to coverage is fantastic, it's always been the underpinning of the Medicaid program and the Medicaid managed care program, but now we're looking at the homeless camps. We're looking at what it actually means to get care to those people where they're situated. And that is a new wrinkle and one about which I think we can all be excited. So thank you for that question.